All right. The first question, we'll start with Dr. Lucero, although I'm going to open up all these questions to all of the speakers. The question is, how can we be more involved with reducing maternal mortality due to maternal hypertension?
So I think the things that you can do at your own institution, obviously it depends on how the structure is, but I think one of the important things is having joint multidisciplinary rounds, and then also some of the things that have been started at institutions, we call it a safety huddle, but something, you can call it whatever you want, but it's a huddle of the team of nurses and OB providers and the anesthesia providers, really asking who's on the labor board, who's in the antepartum board, who are they most worried about, and directly ask questions about hypertensive issues. So those are some of the things. It's really about the multidisciplinary team. Obviously, if there's patients in triage, again, that's part of the huddle. But I think the other issues, we can't do anything about outpatient. That's not where we are at. But anybody on the labor floor, whether it's antepartum, intrapartum, or postpartum or triage, that's sort of our realm, and we're involved in those rounds. So I think safety huddles and morning report are the key ways.
I'd also like to add, just because the mom delivered doesn't mean that you're out of the woods yet. Mm-hmm. And at least with what Dr. Lucero said, that one patient, she delivered and just went and things got worse. So if they're still having, you just got to be very vigilant afterwards too.
All right. Yep. Next question is, if you could expand on the definition of immediately available regarding TOLAC.
So, unfortunately, I really was looking into that as well, and I could not find further detail.
I think it was intentionally made a little vague because part of what happened was when the evolution of the VBAC and doing trial of labor had to be first how much do we need someone to be present in-house from anesthesia and OB, and the practices vary. And so I think the ACOG tried to soften it a little bit so that we weren't going to have patients at places where if the model was the OB isn't even in-house, how are we going to have the anesthesia and the financial aspects of it? So I think it's intentionally vague, and I don't think they're going to make it more specific.
I agree, and that's also why, I mentioned it was unclear why ACOG in their levels of maternal care don't require anesthesia to be in-house or available at all times. So I agree. Mm-hmm. I think it's meant to be vague.
Okay. This is for Dr. Vallejo. The question is, from your experience, can you recommend what techniques other than an epidural would be most effective at relieving a patient's fatigue and anxiety?
That's a tough question. I think the best thing is that it's sort of like a dynamic thing, and as long as you can be involved. So that's why having nurses, even anesthesia, maybe seeing them early, even before you put their labor epidural, give them a realistic expectation. That's why nurses are key in the whole everything, the communication. And, this is what you might expect, and, we want to make it a positive experience. Once it starts to become a negative, maybe you can consider having a labor epidural. You show them the differences. Here's the IV medications we can give you. We might have nitrous oxide. Just show them the whole gamut of what's available, and hopefully just by having enough information, you can continue to make that a positive experience. Did you want?
I agree. I think the other thing that can be done is if you at all have the availability in an outpatient situation to do an education course for the patients, whether it's going to have a group, small group. We do some centering prenatal care, and we come to those patients. And then we also do, Dr. Britton covers on Wednesday nights I forget how often.
About every month.
Yeah, every month she does a really a labor analgesia education seminar, which you could talk more about.
I basically go into all of the patients' labor analgesia options and helping them to understand, basically setting expectations and, yeah.
And they ask lots of questions, right? That's the.
They do ask a lot of questions, yes.
I
So that's
think
what we're here for, as
Yeah.
opposed to like just an online course.
And I think it helps them when we have a lot of interaction with them beforehand, so when they see us on the labor floor, they're really reassured that they'll say, oh, we met you at the labor course or at the centering. So I think that helps allay their anxiety and fears. And, when you have a complication, we've had patients who've had wet taps and they have a post-dural puncture headache. The fact that, we've seen them and talked to them about it, they're actually reassured, and it makes it much easier for us to manage and take care of their headache.
All right. Here's one on gestational hypertension. The question is, for gestational hypertension, do you need a platelet count prior to a neuroaxial block? And what about mild pre-E?
So it's pre-E now. So if it's what used to be called mild is now pre-E, and I think the reason for that is they wanted to not make it sound like it was mild anything. It's a significant disorder. I think when you see a change in someone, and I think generally if someone has gestational hypertension, if their pressures are increasing and they're now becoming in the severe range, the obstetrician would probably be drawing labs for those patients anyway and monitoring them closely. So I think the platelet count will be part of it. And again, looking at the overall trend in the patient's blood pressures and overall health status is going to guide you as whether to get a platelet count. But I think you're probably going to talk to the obstetricians at that point. They're going to want one anyway because they're going to get preeclampsia labs. But I think looking at the status of the patient.
This is in regard to VBAC. What are your thoughts on race and ethnicity affecting the probability of a successful VBAC?
Oh, that's that is Dr. Lucero's.
I didn't say that'd be easy question.
I don't think anybody knows why. It's one of these, you take a large data and look at where the risk factors are, and actually it falls out that Latino and African American women are less likely to be successful. It doesn't mean that they're not going to be successful. It's just one of those, race falls out. Nobody can explain it. I mean, we can't. It's one of those things where we're trying to figure out why African American women are at higher risk of having maternal mortality, and that's something that's really an area that needs to be looked at, and people are looking at it, but we don't really have a question. I don't know if we'll have an answer to that question, but it's something to consider.
There's definitely ethnic differences, and you can look at in the literature, and it tells you which ones are. I'd also like to say I think the successful VBAC also depends on the obstetrician. I can almost tell whoever's on for that day if it's going to be successful or not. So that's a variable too.
I think one of the interesting things is there was a patient that came to me, actually it was a friend of a friend who had been told by her obstetrician and actually the pediatrician, why would you even want to have a VBAC? And her delivery, she had an active phase arrest, and so that's why she ended up getting a C-section. So I agree, that was a huge factor. She really reached out and to others and that was how she connected with me to ask why should I not have it? Why are they worried? Should I try to do this? And we went over her history and what happened, and actually we plugged it into the calculator that Dr. Britton showed, and she actually had a good chance of being successful. The difference is she actually she lived in She lived in Aspen, which I guess nobody in Aspen, Colorado does VBACs or will not let you do a trial of labor. So she actually had to go to Grand Junction, which is an hour and a half away, to deliver. But she was so motivated to do it, and after looking at the calculator and talking to me, she was like, I'm going to do this. She actually was successful and had a successful VBAC. But to just echo that, it's a huge factor is how the obstetrician educates the patient and discusses it.
I'm going to kind of follow on your Colorado story a little bit. There's a question, could there be increased liability if maternal morbidity results from a cesarean delivery in a scenario where the desired or requested TOLAC was refused due to anesthesia staffing issues?
So,
Any speculation on that?
so
I-
just a thought. Do you
Yeah,
follow it?
I don't know.
So they-
Yeah, I mean,
So what I get out of this is maybe since anesthesia is not available, I would allow you to do a TOLAC, but because anesthesia is not there, then we can't do it, so therefore we have to do a C-section. Is that it?
Is that, yeah, is
I
that
think
the-
that's sort of what it was getting at.
I think
yeah, I mean, if they're, that's,
they should probably make the option for a referral to another institution that would allow them to do that. I mean, I think maybe that would probably be the best route to document that.
yeah, I think that's, I mean, I think if I mean, and that's what it's offered to patients. We get a fair number of patients that come from other hospitals because they said, I can't have a TOLAC at that hospital that I'm at, and so it's a late care. I think there's one local hospital that, I don't know if they've changed yet, but we would get a lot of patients that would come for that particular reason.
I was just going to say, I think it speaks to the need for anesthesia and the obstetricians to be in good communication about staffing so that this can be brought up in the antepartum clinic when they're figuring out their birth plan and what's likely.
Give them
There's
options.
also plenty of procedures, for example, cardiac anesthesia and cabbages and things. And if you do certain procedures like less than 50, your complication rates go up tremendously. So if it's a local hospital and they're not doing a lot of TOLACs, then it's probably not a good idea, and you're better off at a place that is used to doing it.
Yeah.
This next one's for Dr. Vallejo. The question is, when you're counseling women about epidurals, do you mention the benefit of improving fatigue and anxiety? And if so, what do you say?
Yeah. No, not really, but it's nice to know that the three are correlated. And yeah, I just try and really be a positive influence to the mom. A lot of times they're coming in and they're just so anxious and they're nervous. So just showing a positive attitude, and yes, we're going to take care of you, and we want it to be a positive experience. As soon as it becomes negative, and you know, I think all women should feel contractions, and once it becomes negative and they can have it, then we can take care of it. And I try and tell them, I sort of, you know, joke with them a little bit and say, we give happy durals, and you'll get a happy dural. We're going to give you happy juice. You can hit the happy button, and it's better than going to McDonald's and a Happy Meal because you get all this happy stuff. So a lot of times just a positive attitude and being available and seeing what their needs and wants are and just being available to help them.
I feel like so many times we are focusing on communicating what the risks are to the patient. So I think that's actually something that would maybe worth mentioning to them that might alleviate their anxiety about the whole process.
The next question is for Dr. Lucero. In the case where you need to perform general anesthesia for cesarean section in a patient who is a preeclamptic with severe features secondary to hypertension, what do you use to blunt the hypertensive response to laryngoscopy? And they were given examples like beta blockers, remifentanil, so on. What's your preference?
So I think I do a little bit of a different approach for how I maintain the anesthesia, and obviously we'll do, you can use fentanyl. I don't use remifentanil for induction, but I do use a combination of remifentanil and propofol for the C-section. And I find that when I use the remifentanil, I can lower the dose of the propofol that I give, and I don't have to use any volatile agent. So obviously if there's atony issues, it's not, we can dispense with it's from general anesthesia. So we try to educate our obstetricians that anesthesia can be delivered, it's a state of mind, it can be delivered in different ways. So their impression was always that if they're under general, that means that they're always going to have atony, and that's the contributor. So we have educated them that it depends on what I'm giving. So I change it a little bit, but generally if they're, we can give them some fentanyl and deepen it, and it's an RSI, so we kind of watch that carefully. I don't feel that I need to put in for all patients with preeclampsia. I'm not doing A-lines. I don't think anybody else can comment about that, but it's definitely something that is a critical time, and we're going to aggressively treat those patients, and we may, preemptively, if they're struggling to keep their pressure. I've used hydralazine, which works really well. It's just you have to give it time.
I guess the only other thing I was going to comment on that a little bit is just ACOG's recommendation that even though you're lowering the pressure to get it below 160 over 110, you don't want to go too low,
Right.
and ideally you'd still like the systolics to be in the 140s to 150s, so you have to be mindful in both directions.
Yeah, which is a good point. The placenta is perfusion pressure dependent, and it's spent the extent of the pregnancy establishing, that's why their pressure is high, and trying to establish oxygenation to the fetus. You need to keep it, you certainly don't want it in stroke range, which Dr. Rollins was saying, you don't really want to get it above 160. That's the goal, to get it down, but you don't want to drop it to 90s either. You have to kind of be in that 130s, 140s range, because that's what the placenta is used to seeing, a higher level, and is going to need to oxygenate the fetus. So that's a critical time when you're doing the induction, to keep it below the stroke range, but not too low.
Okay, we'll do one more, and then we'll let y'all go. This question is about augmentation of labor in the setting of TOLAC. Okay, and just the question is, the person saying it's a bit controversial among their obstetricians, and what should we know about, as anesthesiologists, about increased risk of uterine rupture or issues with augmentation in a TOLAC patient?
So my understanding is that misoprostol is not, is contraindicated for TOLAC. But that's something that, you'd have to discuss with the obstetrician at your institution. But it does, I think that's, you have anything else to add?
Yeah, I think it's if you use any prostaglandin, you're going to increase, in someone who's had a previous scar, you're going to, that is contraindicated. So something like Cervidil or misoprostol. When the question is augmentation, there's the induction of labor, which I think when Dr. Britton showed the slide, anybody who goes into spontaneous labor is actually going to have a very successful, their chance of having a successful VBAC is quite high. When you have somebody that, as I talked about, inducing, and so as we start to get into the induction for post-dates, those patients who've had a previous scar, it's going to be challenging, you're limited, and so really what you have to look at is a Foley balloon for induction and cervical ripening. But if you're augmenting, Pitocin is fine to give. If someone's in spontaneous labor and, let's say their contractions aren't as frequent, then the oxytocin is absolutely fine to give. And I think that was something that Dr. Britton had talked about. As far as the other augmentations, I don't know what other, I think those
that
are the...
covers it.
Yeah.
But if you're looking at it from the standpoint of likelihood of VBAC, then yes, augmentation would decrease the likelihood.
All right, thanks for your attention. There's a coffee break that follows. Please come back at 10:30. For those of you who didn't get your questions answered, feel free to come up or find the speakers at some point later in the conference.
Want to do 10?
Do we have time?
Do you guys want to do, it's 9:30, do you want to do 10 o'clock?
Sorry. All right.
10 o'clock?
10
Okay,
o'clock.
let's do 10, all right.
This is my, mic check.